evening, everyone, and welcome to this podcast from the Standards of Practice Committee at the ASGE. This is Bashar Qumseya. I'm the past chair of the Standards of Practice Committee, and I'm here to discuss with you our most recent guidelines about ergonomics and endoscopy-related injury. And I'm happy to be joined today by my good friends who are the first and lead authors of this very important guideline, Swati Pawa, Richard, Kwon, and Douglas Fishman. Thank you guys for being here, and welcome to the podcast.
Thank you.
Thanks for having us.
Yeah, this is a very important document because normally in ASGE we'll deal with guidelines related to the role of endoscopy in various things. But in this guideline, we decided to discuss what interventions can we do to minimize the risk of endoscopy-related injury. So I'll start with Swati. Can you please tell us what are endoscopy-related injuries and why are they important?
Sure. So endoscopy-related injuries are musculoskeletal disorders, which are due to the repetitive use of the endoscope. And because of this repetitive use over long periods of time, day in and day out, and also prolonged standing, and also scoping in awkward positions to maneuver a sharp turn or otherwise, we are repetitively using these our muscles, joints, and our tendons in mostly non-neutral positions, generating very high biochemical loads, which then overpower our tissues and cause microtrauma to the connective tissue, leading to work-related musculoskeletal injury, which then manifests as just maybe aching or aching pains during the course of endoscopy, but feeling good when we go home. And so we're not really changing our schedule much, or we keep going on, and then this increases to just more pain and more stiffness maybe when we are done and going through into the night, and the pain continues, and then more weakness, more fatigue, leading to disability. And that's why it's important.
Excellent. Thank you so much. So obviously this topic is important to everybody who does endoscopy, and many of us have experienced some of these symptoms. So I know, Swati, we've done a systematic review and we looked at the rates of injury, of endoscopy-related injury among practicing endoscopists. Can you tell us what we found in that review?
Yeah, sure. So, there's been data out there regarding endoscopy-related injuries as far back in the 90s, but more recently in the last 5 years, there's been just a lot of data that's come out relating to endoscopic-related injury. We did a meta-analysis of about 17 studies, most of which were practicing gastroenterologists. And we found that the prevalence of ERI was about 58%. It's ranged between 40 to 90% in most surveys. So that's what we found.
So 58% is a staggering number. That
Yes.
means more than half of endoscopists experience endoscopy-related injuries. That's very important. What are some of the common sites that we have uncovered during our systematic review?
Sure. And so the most common sites that we uncovered during our meta-analysis were the hands and the fingers and the back and neck. These were the most common sites. Again, related to posture, especially the back and the neck, which could be the way your table's placed or the way your monitor is placed, and also high forces, which are then the hands and the fingers.
Excellent.
Foreshadowing.
Good.
What's that?
I said foreshadowing.
Okay.
Excellent. Thank you so much, guys. Doug, can you tell us, we also looked at the predictors of injury for endoscopy-related injury. Can you tell us what we found as far as what are some of the predictors of people who are at higher risk of getting endoscopy-related injuries compared to others?
Sure. So two major things that came out, and one was being a female gender, and the other was volume. And so when we look at the systematic review, 8 studies, 3,300 GI respondents total, it was 62% of females had experienced ERI to 45%. So again, still both very important and large numbers, but 62% again, beyond being statistically significant, makes us think about some of the factors that might be involved in female versus male, for sure. That might be hand size, that might be other, proportional things that might happen. We certainly know during pregnancy there are changes that can occur, and you can have injuries independent of endoscopy. When we think about volume, certainly the more you do, the more of these micro traumas and even more significant traumas you can have. The longer your case lasts, et cetera, the longer, again, the longer time, the more ergonomically incompatible endoscopy is with our day-to-day. So in this specific question, this was actually a paper Swati did, published with the ACG a few years ago, over 1,700 respondents, and again, more than 15 years in practice, certainly conveyed a greater risk of endoscopic-related injury.
Excellent. So the more you are in practice, the more likely you are to get these, and also the more cases you do per day, and the longer the work day is. If you do half a day of endoscopy compared if you do a full day of endoscopy, we also showed data that is associated with increased risk of endoscopy-related injury. Excellent. So we talked about the rates of injury. We talked about the predictors of injury. Most of the document focuses on what can we do to minimize endoscopy-related injury. And in this guideline, we made 3 strong recommendations and 2 conditional recommendations. Rich, do you want to lead us off and tell us about some of the important strong recommendations we made to minimize endoscopy-related injuries?
Sure. The very first strong recommendation we made was a very basic one, in that we recommend some sort of ergonomic education for anyone who does endoscopy. The benefits of this are for everyone, whether you're a trainee or an experienced endoscopist. In the literature, the form of education has taken all sorts of different forms. They've ranged from as passive as posters on a wall to didactic lectures, short videos, and those kinds of things. And even those passive and not very active interventions actually have a benefit. They have a benefit we've shown in terms of just ergonomic awareness. And then when you do actually more formal physical assessments, they actually lead to improvement, which when you improve the scores of these assessments, that means your risk of injury goes down. And we also know there's a study that looked at the sustained effect of education, and we know that 6 weeks after that, there's those that get training still do better on these physical assessments. The ultimate education would be some sort of individualized training from physical therapists, and there are studies from Miami that looked at this, and what they showed was that there was great benefit when there was an individualized, formalized physical assessment therapy by physical therapists, and those patients, those endoscopists, whether they were trainees or at higher levels of training, benefited greatly from education. So from our standpoint, it's obvious that education has a strong benefit. We don't know what is the best form of education, but we recommend that some form of education be provided for anyone performing endoscopy.
Excellent. So again, we showed that the rates of injury are very high, and everybody needs to be aware of that. So education, as you said, and as we strongly recommended here, is the first step that anybody can take to educate ourselves, educate our fellows, division chiefs, chiefs of endoscopy, everybody who is in a position to be able to spread the awareness about this topic is strongly recommended by the ASG in this guideline to do so. And in raising awareness, we hope that we can decrease the rates of endoscopy-related injury for future endoscopists and for ourselves as well. Excellent. Thank you so much. What about so everybody should be educated about this. What else can we do? We made 2 additional strong recommendations. Doug, do you want to tell us about those? What else can you do when you are during endoscopy? What can you do to minimize the risk of endoscopy-related injuries?
Sure, and I think this is one that affects us on a day-to-day basis, but the ASG recommends a neutral monitor position during endoscopy to reduce ERI, and that was a strong recommendation, as you said. And monitor position is important because of neck strain. That's again one of the more common injuries, and certainly again affecting the whole thing of what we're doing is looking. And so having a neutral basically at eye level, used to think that we needed to be a lot higher, but so having a relatively neutral eye position such that your eye angle is looking basically at the monitor. Softly that suggests that having a adjustable monitor would be important as well. That certainly plays into our neck flexion and extension, depending on what we're doing. And if you think about more advanced things and more movement, certainly that becomes really important. So I think that's was the major piece here in terms of our positioning, but also distance, relative distance to the screen, such that the monitor should be directly in front of you, not to the right or to the left. And also we make some suggestions about distance away from you and where the monitor should be for the optimal viewing and to be able to reach that certain focal point to see critical findings. The other recommendation is a strong recommendation that we recommended a neutral bed height to reduce the risk of ERI. And again, certainly depends on the procedure you're doing and the movements that you're using. But certainly, and again, also taken from the laparoscopic literature, again, is keeping that neutral bed height for both your back as well as your neck and your arm muscles. So again, that I think is a really important thing to think about, again, specifically in procedures where there is a lot of variable movement, colonoscopy, ERCP, et cetera.
Thank you so much, Doug. So these are important recommendations here. And in the setting of endoscopists, specifically in the US setting, these are probably easily done. Most of us work in situations where the monitor level can be adjusted, the location of the monitor can be adjusted, and definitely the stretcher or the table can be adjusted so you have a neutral position. So every endoscopist should take these recommendations seriously. And I know, for example, before I start a case, just like when you're teaching somebody to drive a car, you adjust the mirrors, you adjust the seat, you also need to adjust the monitor and adjust the table height so that you are comfortable and not exerting too much tension on your joints. Thank you so much for that. We also, Swati, made two conditional recommendations, which are still important recommendations. Can you please tell us about those? What else can we do during endoscopy and in between procedures to help us minimize the risk of injury?
So I think one of them that stood out was micro breaks. And again, they've been on our review of literature, they were defined differently in surgical literature and then also in the national survey, which is the largest survey to date that was conducted a few years ago. In that survey, we defined it as just a meaningful break, maybe lasting from 30 seconds to 2 minutes, and just kind of taking a break, a pause, and relaxing your muscles, which might have been contracted by now because of those long procedures if you were doing, and converting some of that static load into dynamic load in terms of getting the blood supply to the muscles and things like that. And then in surgical literature, they talked about targeted stretching micro breaks, where they actually had their surgeons break every 40 minutes or so for 2 minutes, where they would do targeting exercises to various parts of the joint, various joints, be it the knee, the shoulder, the neck, and noticed increased performance, less post-procedure pain, increased mental focus, and no change in the no difference in the outcome of the surgery. So those were the two big ones. Interestingly, the national survey showed that people who took micro breaks had lesser odds of developing ERI. It also showed that people who took macro breaks, which are then actually scheduled breaks, be it a 15 to 45-minute lunch break in the middle of your schedule that administration has put there, any kind of break was associated with lesser ERI. It didn't matter the duration of the break. So that was important. And this can be done easily, especially the micro breaks or stretching. Or stretching in your micro breaks can be done easily on your downtime. You can even do it while you're doing a long procedure. And again, we have made reference to some of the ASG websites, which have some of these videos and tapes available, which are showing these exercises that you can perform during micro breaks.
Excellent. So again, those are important recommendations and can be easily incorporated. I know many of us are so busy that we forget to take a break, or we don't take a lunch break, and we want to keep going. But it is very important, if you have long days of endoscopy, to schedule a break, do some stretching, walk around, release the tension on your joints, release the tension on your neck, and taking those micro breaks in between procedures. You know, our procedures, especially in general endoscopy, i.e. non-advanced endoscopy procedures, are not very long. So taking a break in between procedures to take time to stretch. I've made it a habit when I have a long day of colonoscopies, for example, I will ask everybody to stretch with me, you know, before the first case and in between cases. And it's kind of a fun effort to do as a team where we all start stretching. It looks funny, but it feels good. And, you know, we laugh about it and have a good time. So I want to thank you all so much. You have worked so hard on this guideline. This is a very important guideline. It affects everybody who does endoscopy. And we hope that by spreading awareness about this, by adjusting the table height, by adjusting the monitor, by using a mat, by using breaks, that we can make a change in the lives of all of us for the better and decrease the rates of endoscopy-related injuries, which can be catastrophic to some of endoscopists who unfortunately can even go into disability because of these short-term or even long-term. So again, thank you guys so much for being here and for the effort you put in this document. We encourage everybody to read our document, which comes out in GIE, and it includes the summary document and includes a visual abstract, which you can just look at it and maybe post it in your endoscopy suite to remind you of what you need to do every time you do an endoscopy. And also we have a methodology section or a paper if you are inclined to see all the 3-4 years worth of work that we put in, then you can read that as well. Thank you so much again. And it was a pleasure working with all of you, and have a great day.
Likewise. Thanks,
Thank you.
Bashar.
Thank you.
Everyone. Bye.
Thank